Modern pandemic response rests on three pillars: testing, tracing, and treatment. The first pillar, testing, is the most critical. Without a test, you cannot confirm a single case. Without confirmed cases, you cannot trace contacts. Without confirmed cases, you cannot test treatments or vaccines. The entire system collapses. This video examines a specific worst-case scenario. A novel pathogen emerges. It is contagious, likely airborne, or droplet spread. It has a significant mortality rate, possibly between 5% and 15%. But unlike every major pathogen we have faced, including HIV, Ebola, SARS, COVID-19, and influenza, this one cannot be detected by any existing medical technology. No PCR test, no antigen test, no antibody test, no visible signature under any microscope, no unique biomarker in blood, urine, or spinal fluid. It does not trigger a distinguishable immune response. It hides completely within the human body while causing progressive damage. What follows is a systematic breakdown of consequences. Each consequence is grounded in real public health mechanisms applied to this fictional but plausible scenario. The first consequence occurs before anyone even knows there is a disease. In a normal outbreak, the first few cases, called index cases, trigger alerts. A patient presents with unusual symptoms. Doctors run tests. A novel pathogen is identified. Public health agencies are notified within days or weeks. In this scenario, that never happens. Because the disease has no detectable signature, patients who seek medical care receive negative tests for everything. They are diagnosed with vague conditions: viral syndrome, fatigue, stress, anxiety, or idiopathic organ dysfunction. No single doctor sees a pattern because the symptoms are non-specific. Mild fever, occasional dizziness, intermittent confusion, slowly declining organ function. By the time any clinician suspects a novel disease, hundreds or thousands of cases have already occurred. But without a test, there is no way to confirm the suspicion. The disease spreads silently for weeks or months, entirely invisible to surveillance systems that require laboratory confirmation. The consequence is a delayed response measured in exponential growth. Every week of invisibility doubles or triples the number of infected individuals. The second consequence is statistical invisibility. When infected individuals die, their deaths are not attributed to the novel disease. They receive other official causes based on presenting symptoms. A patient whose lungs fail receives a cause of death of respiratory failure. A patient whose heart stops receives cardiac arrest. A patient who experiences a seizure and dies receives status epilepticus. These are technically correct but fundamentally misleading. The underlying cause, the undetectable pathogen, never appears on any death certificate. No algorithm connects these deaths because they appear under dozens of different codes across different organ systems. The result is that mortality appears as background noise. Every city normally experiences a certain number of unexplained cardiac deaths, strokes, and respiratory failures. This disease simply adds to those numbers without creating a visible statistical spike large enough to trigger alarm. Public health officials continue to see normal seasonal variation. They have no signal that a novel killer is active. The disease achieves complete epidemiological camouflage. Contact tracing is the second pillar of pandemic response. It requires three things: a confirmed index case, a list of contacts, and a test to determine which contacts are infected. In this scenario, all three fail. Without a confirmed case, there is nothing to trace. Even if health officials suspect an outbreak, they cannot identify who is infected and who is not. They cannot quarantine the contagious because they cannot distinguish them from the healthy. They cannot notify exposed individuals because they cannot confirm exposure without a test. The consequence is uncontrolled spread. The reproductive number, ROSO, remains at its maximum potential because no interventions can target specific individuals. General measures like mask mandates and social distancing may reduce spread, but they are blunt instruments. Without targeted isolation of confirmed cases, the disease continues to move through populations exponentially. Historical comparison. During the 2014 Ebola outbreak, rapid testing and contact tracing stopped the spread in Nigeria after only 20 cases. Without testing, that outcome is impossible. This disease would spread until it reaches herd immunity through infection, a process that would kill millions. The fourth consequence affects the relationship between patients and doctors. When patients repeatedly present with severe symptoms and repeatedly receive negative tests, the medical system defaults to a common explanation: psychosomatic illness. This is not malpractice, it is standard diagnostic logic. When all organic causes are ruled out, the remaining category is functional or psychological. However, in this scenario, that logic is fatally wrong. Patients truly have an organic disease that cannot be detected. But doctors acting on available evidence will tell them their symptoms are stress-related or anxiety-driven. Patients will be prescribed antidepressants, referred to psychiatrists, or discharged without treatment. The consequence has two parts. First, patients suffer and die without any medical support. Their legitimate symptoms are dismissed. They stop seeking care. They die at home alone, believing that no one believes them. Second, trust in medical institutions collapses. Once the disease becomes undeniable, when enough people have died that a pattern emerges, patients remember being dismissed. That memory erodes faith in doctors, hospitals, and public health agencies for decades. The fifth consequence is perhaps the most severe from a medical perspective. Developing a treatment or vaccine requires knowing what you are targeting. You need to isolate the pathogen. You need to understand its structure. You need to test candidate drugs or vaccines in infected individuals. You need to measure whether those interventions reduce viral load or immune response. In a truly untestable disease, none of this is possible. You cannot run a clinical trial because you cannot identify infected patients. You cannot measure viral load because you cannot detect the virus. You cannot measure immune response because the infection does not produce a distinguishable immune signature. You are attempting to treat an enemy you cannot see, measure, or confirm. The consequence is that supportive care, treating symptoms like respiratory failure or kidney damage, becomes the only available medicine. Patients receive ventilators, dialysis, and blood transfusions, but the underlying disease continues unchecked. Mortality rates remain at the pathogen's natural level. No medical intervention reduces deaths. Vaccine development is similarly impossible. Without a way to measure who is protected, clinical trials cannot determine efficacy. Even if a candidate vaccine were developed, you could not prove it worked. Regulatory agencies would not approve it. The world would face this disease without pharmaceutical tools for years or decades. The sixth consequence is economic, but it flows directly from the testing failure. During COVID-19, testing allowed targeted lockdowns. Cities and countries could identify hotspots, close specific businesses, and isolate specific neighborhoods while leaving the rest of the economy open. Testing provided the data for surgical interventions. Without testing, that becomes impossible. Governments face a binary choice: do nothing and let the disease spread uncontrolled, or shut down everything and hope to slow transmission. History suggests governments will choose both options in sequence. Initially, they will attempt minimal measures because they cannot confirm the threat. As deaths rise, they will impose blanket shutdowns. Schools closed, businesses closed, travel banned. But without testing, they cannot know when it is safe to reopen. Lockdowns will last months or years, causing economic damage far exceeding COVID-19. Specific consequences include global supply chain fragmentation, mass unemployment exceeding 30%, collapse of hospitality and travel industries, bankruptcy of small businesses, housing crises as mortgages go unpaid, and famine in regions dependent on food imports. The indirect mortality from economic collapse, suicide, malnutrition, untreated chronic disease will likely exceed direct deaths from the pathogen. The seventh consequence is the erosion of civil liberties. When governments face a deadly threat they cannot measure, they eventually abandon evidence-based policy. There is no evidence to base policy on. They fall back on geographic and demographic proxies. Concrete outcomes include entire cities or regions placed under quarantine based on death rates alone. Travel bans applied to postal codes, not individuals. Checkpoints preventing movement between neighborhoods. Military enforcement of curfews. Surveillance systems tracking movement rather than infection. Because no test exists, these measures apply to everyone in the affected area, healthy and sick alike. The distinction between infected and uninfected becomes meaningless. People are confined not because they are contagious, but because of where they live. This creates perverse incentives. Healthy individuals have no way to prove their health. They cannot obtain certificates of clearance because no test exists. They cannot travel, work, or access services.
Where is your clearance certificate? There is no test. There is no certificate.
Social and economic life fragments into isolated geographic cells. The universal human right to free movement is suspended indefinitely. Historical parallel. During the Black Death, cities without diagnostic capability resorted to geographic quarantine. The same pattern would repeat, but on a global scale and with modern surveillance technology. Modern response relies on data, counts, rates, curves, shared reality. When data vanishes, shared reality vanishes with it. Dashboards go blank, maps lose their dots. Without tests, no cases, only stories and rumors. Anecdote replaces measurement. Rumors swamp expertise. Communities construct truths from who they know and lose.
It's not real. It's everywhere. A plot. Punishment.
Each claim finds evidence. None can be disproven. Scapegoats follow uncertainty. Violence follows scapegoats. An unmeasurable threat breaks knowledge before bodies. Without tests, coordination dies. Fragmentation and harm fill the void. The ninth consequence is the destruction of routine medical care. Hospitals have limited capacity. In a detectable outbreak, they can surge resources to known hotspots. They can discharge stable patients, cancel elective procedures, and convert wards to infectious disease units based on test-confirmed caseloads. Without testing, hospitals cannot distinguish between COVID-like patients and patients with other conditions. They must treat everyone as potentially infectious, consuming massive resources in personal protective equipment and isolation rooms. Alternatively, they treat no one as infectious and risk spreading the disease throughout the facility. Neither approach works. The likely outcome is that hospitals become overwhelmed not by confirmed cases, but by suspected cases. Every patient with fever, cough, or fatigue is treated as a potential carrier. Emergency rooms clog with people seeking answers no test can provide. Routine care, cancer treatment, surgery, dialysis halts because beds and staff are consumed by the undiagnosed. Mortality from preventable conditions will skyrocket. Cancer that would have been cured becomes fatal. Appendicitis that would have been treated becomes peritonitis and death. Heart attacks and strokes that would have received emergency intervention go untreated. The collateral damage from health system collapse exceeds the direct damage from the pathogen. This scenario is not a prediction. It is a stress test of our global public health infrastructure. The conclusion of that stress test is failure. Current systems assume detectability. Surveillance networks assume laboratory confirmation. Vaccine development assumes an identifiable target. Contact tracing assumes a test. Without these assumptions, every pillar of pandemic response collapses sequentially. The consequences outlined here, invisible spread, misattributed deaths, impossible treatment, economic collapse, civil liberty erosion, conspiracies, health system failure, are not speculative exaggerations. They are logical deductions from the absence of testing. No country has a contingency plan for an undetectable pathogen. No stockpile contains untargeted diagnostic platforms. No research pipeline is actively developing tests for unknown unknowns.
I'll be back.